Hi, everyone. Thanks for joining me. My name is Nancy Malek. I'm an anaesthetic specialist working in Sydney, Australia. Now, before I begin, I'd like to provide some background. This is a presentation I recently gave to my anaesthetic colleagues designed to present the science and some of the Australian statistics around COVID. Some of you asked to see the presentation, so I hope this can serve as an example of medical education. And because I believe that all doctors have a duty of care to learn about COVID. So with that in mind, here's my presentation. I know that COVID is polarizing. So before we discuss the statistics and the science, I'd like to tell you a story. This is the story of a doctor named Semmelweis and the legacy he left, known as the Semmelweis reflex. Dr. Ignaz Semmelweis was a Hungarian obstetrician who in 1847 made some simple observations on the maternity ward. He observed that when midwives washed their hands, there was a profound decrease in the rate of postpartum sepsis and death in new mothers. He started collecting some data, and he found that washing hands resulted in 2% mortality, and not washing hands resulted in 18% mortality. So he was really excited, and he went to his colleagues and he said, "Hey guys, we should start washing our hands." But they were so offended and so resentful that they ridiculed him and banished him because he was speaking out against established dogma. They believed that disease came from bad humors and, ironically, bad air. And they were gentlemen. Gentlemen didn't have disease on their hands, let alone transmit it. So they said, absolutely not. We'll continue as we are. And so these new mothers continued to get sick and die. Now, it's not like he was asking them to wash their hands with mildly scented, moisturizing, skin-friendly detergents that we use. No, he was suggesting smelly, uncomfortable chlorine solutions. So he was ridiculed and banished, and he ended up in a mental asylum. The biggest tragedy is that he died of sepsis from an infected wound on his hand that he sustained after being beaten by the asylum guards. It was several decades later that Louis Pasteur put forward germ theory. And after that, a surgeon called Lister came along and said, "Hey, we should wash our hands." And this time, everyone said, "Yes, absolutely, let's wash our hands." And they called Lister the father of modern surgery. So back to the Semmelweis reflex. It's the reflex tendency to reject new knowledge or even scientific evidence when it contradicts established knowledge, beliefs, norms, or paradigms, especially when the knowledge or evidence is inconvenient or uncomfortable. So here we are in 2025, in the 6th year of a global pandemic with a novel pathogen, and it seems that history is repeating. Now, before I go any further, I'd like to say a huge thank you to my friends in the World Health Network. The WHN is a huge international community I've recently become a part of. They've given me advice, support, and encouragement, and generously offered suggestions and even resources. I'm really lucky to be part of a community who continue to follow the science and take COVID seriously. I'd also like to thank my friend Adrian Lewin, an epidemiologist who was a huge asset in deciphering the literature and preparing this talk. The outline for tonight is to first look at the Australian mortality statistics, comparing COVID mortality with road fatalities. Then we'll start with the basics of virology, and then acute and chronic disease, including mechanisms. Then I'll present 2 articles related to COVID's effect on the brain, and then move on to how it spreads with information pertaining to my hospital's operating theatres, and finally, some solutions or mitigating strategies. How do we mitigate against something we can't see? Here's a 2-minute video created in 2023 by the John Snow Project. It has an interesting narrative.
When an Australian dies on our roads, it's a tragedy. We hear their names. We see their faces. They're not just a number. They are a reminder to do better. We choose to prevent. We redesign, we innovate, we test, we secure, we check, we double check, we warn, we enforce, we fix, we maintain, we train, we look, we wait. We use multiple layers of defence every day to prevent every road death we can. But when an Australian dies of COVID-19, it's not a tragedy. It's just a number too big to ignore. Right now, COVID-19 is already 12 times more deadly than our roads. Yet our government has chosen to ignore it. Relying on current vaccines alone is never going to work. But we can prevent infections in the first place by wearing well-fitting respirators when sharing air, by cleaning the air with filtration and ventilation, by supporting people to test and isolate when sick. Because living with COVID is not really living.
It's an interesting discrepancy, isn't it? I contacted the Australian Bureau of Statistics, and they very helpfully responded with these numbers. As it turns out, deaths from COVID outnumber road fatalities by a factor of 3.4. Isn't it interesting that we've decided to live with COVID? So we've talked a bit about numbers. Now let's look at the science. We're starting with the basics so we can build on this knowledge in the future. Terminology first. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is the virus responsible for COVID-19, or COVID. For simplicity, I'll be using the term COVID to mean both the virus and the disease. Its structure: it's an enveloped RNA virus, so called because the surface spike proteins give it a corona or crown-like appearance. Its size is 50 to 140 nanometers, on average 100 nanometers in diameter, equal to 0.1 micrometers. And this becomes important when we talk about spread. Each spike protein consists of 3 monomers with 2 subunits each. Below that, you can see the S1 subunit, which contains the receptor binding domain for binding to the ACE2 receptor. The S2 subunit undergoes conformational change after binding to allow merging of the viral envelope with the host cell membrane. Also know that the spike proteins are heavily glycosylated, which allows them to evade the host immune system. The virus then replicates inside the host cell. New virions get released by exocytosis, and then new host cells can be infected. Viral replication triggers macrophages, neutrophils, and dendritic cells to release inflammatory cytokines such as interferons and interleukins, and these recruit antibodies and T cells. Concurrently, COVID infects endothelial cells, which causes inflammation, activates the complement system and platelets, and can result in possible amyloid microthrombosis. The interplay between viral replication, immune function or dysfunction, and endothelial dysfunction determines the disease severity, from completely asymptomatic all the way to multi-organ failure and death. Where are ACE2 receptors located? In the respiratory system, they're on the ciliated epithelium of the nose, pharynx, trachea, and bronchi, as well as the middle ear and goblet cells and type 2 alveolar cells. In the cardiovascular system, they're on cardiac myocytes and, most importantly, endothelial cells, because endothelial cells are everywhere. In the central nervous system, they're in the olfactory bulb, various neurons and astrocytes. They're also in the organs of the gastrointestinal tract, the liver, kidneys, male and female reproductive organs, skeletal muscle, and cartilage. COVID can enter and infect any cell which has an ACE2 receptor. I hope to dispel some common myths tonight. The first one is COVID is a respiratory disease that's confined to the lungs. In fact, COVID is a multi-system disease that affects multiple organs and blood vessels. Here are the mechanisms of some common respiratory viruses for comparison. Note that all of these viruses are a similar size to COVID. Influenza binds via sialic acid receptors in the upper and lower respiratory tract. RSV binds via nucleolin in airway epithelial cells. Rhinovirus binds via ICAM1 in nasal epithelium and upper airway lymphoid tissue. Again, from the Australian Bureau of Statistics, here are the deaths from influenza and COVID in Australia from 2022 to 2024. Each year, deaths from COVID have outnumbered deaths from influenza by a factor of between 5 and 33 times. Here's the next myth. COVID is like the flu, or it's just a cold. In fact, COVID is mechanistically different to and more lethal than influenza, RSV, and rhinovirus. Now we move on to the chronic form of COVID. It was first termed long COVID by patients and citizen scientists. It's also called post-acute sequelae of COVID, or PASC. The most comprehensive definition of long COVID was formulated by the National Academies of Science, Engineering, and Medicine, who were tasked with developing an improved definition for long COVID by the American Department of Health and Human Services. That definition is, in brief, the persistence of one or multiple symptoms after a COVID infection that lasts for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. Some important things to note. Long COVID can follow asymptomatic, mild, moderate, or severe COVID. It can be continuous from the time of COVID or have a delayed onset, sometimes weeks or months after apparent recovery. Most long COVID cases follow a mild infection. Over 200 symptoms have been described. There's currently no available diagnostic biomarker, so it's a clinical diagnosis. And although novel therapies are in development, there are no validated or effective treatments. The Australian Institute of Health and Welfare has estimated that 5 to 10% of individuals infected with COVID may develop long COVID with each infection. Some studies quote up to 30%. My focus is on adult COVID, but a systematic review and meta-analysis led by a professor of neuroscience and the Harvard School of Public Health found that the prevalence of long COVID in children was 25%. With the most common symptoms being fatigue, mood symptoms, and sleep disorders. And children can also commonly get dyspnea, post-exertional malaise, which we'll define in a moment, memory loss, headaches, and orthostatic intolerance. So from this, it could be that more people have long COVID than we first realized because we're not asking the right questions, and therefore we're not recognizing it. Here's a schematic from a review article in the journal Nature Reviews Microbiology in 2023. It features some commonly described symptoms and conditions, but this is not an exhaustive list. Some of the symptoms and conditions include chest pain, palpitations, postural orthostatic tachycardia syndrome or POTS, cough, shortness of breath, mast cell activation syndrome or MCAS, diabetes, which is generally type 2 in adults and type 1 in children, abdominal pain, nausea, cognitive impairment, which has been likened to drink driving, fatigue that is not improved by rest, memory problems, tinnitus, dysautonomia, deep venous thrombosis or pulmonary embolism, and also tension headache or migraine, hair loss, hyperlipidemia, bloating, constipation or diarrhea, anxiety or mood disorders, myalgia, arthralgia, and post-exertional malaise. This is an interesting phenomenon. It causes worsening or new symptoms up to 48 hours post-physical or even cognitive exertion, usually lasting days to weeks or even much longer. So that means a person will feel that they have the energy for a task, whether it's physical or cognitive, then they'll do that task, and 24 to 48 hours later, they'll experience a crash with long-lasting worsening of their symptoms or the onset of new symptoms. And lastly, I need to mention erectile dysfunction and changes of the menstrual period. Both are thought to be mediated by viral persistence and endothelial dysfunction. And we'll come to mechanisms next. There are 4 main mechanisms thought to underlie long COVID. These have been published in multiple journals and here from the Annals of the New York Academy of Sciences in 2024. The first mechanism is viral persistence. Viral persistence causes chronic inflammation and ongoing symptoms. Viral proteins and whole virus have been found in the brain, heart, lungs, liver, gut, muscles, eyes, lymph nodes, and reproductive organs. The second mechanism is immune dysregulation. This is chronic T-cell activation leading to T-cell exhaustion, reduced CD4+ and CD8+ effector memory cells, autoantibodies to ACE2 receptors, endothelial cells, and organs such as the lungs and gut. Here's another example of immune dysregulation. Does anyone recognize their weakened immune system? The third mechanism is reactivation of dormant viruses and/or microbiome dysbiosis. Reactivation of any latent virus can occur, including Epstein-Barr virus, herpes virus, cytomegalovirus, and shingles. The fourth mechanism is macroscopic or microscopic direct tissue damage. This is chronic inflammation, endothelial injury, cell hypoxia, and mitochondrial damage. So here's the next myth. COVID is mild and self-limiting. In fact, according to the Australian Institute of Health and Welfare, the risk of long COVID in Australia is estimated to be 5 to 10% per COVID infection, and the risk is cumulative. Now let's talk about COVID and the brain. I have 2 studies to discuss. The first one is a study from the UK Biobank, which is a public health database in the UK. Researchers performed MRIs on 401 patients, both before and after their COVID infection, as well as in 384 matched controls who had no record of COVID. It was published in the journal Nature in 2022. The main findings from these figures are that the COVID group had a 1 to 2% greater reduction in grey matter thickness of the parahippocampal gyrus compared to the non-COVID group. This area of the brain is involved in making integrated decisions using sensory and emotional information. They found a similar pattern in the orbitofrontal cortex with a 2% greater reduction in grey matter thickness compared to controls, and this area of the brain is involved in spatial and episodic memory. Now, you might think that these changes are small, but normal aging results in only 0.2 to 0.3% change per year. They also undertook cognitive tests on both the COVID group and the controls called Trail A and Trail B. For Trail A, a numeric test, the COVID group took 7.8% longer to complete the test. Even after excluding 15 patients who'd been hospitalized with COVID, the COVID group still took 6.5% longer to complete the test. For Trail B, an alphanumeric test, the COVID group took 12.2% longer, and about the same even when the 15 hospitalized patients were excluded. In other words, the COVID group had worse executive function. Now for the second brain study. This study in the New England Journal of Medicine in 2024 invited 800,000 adults in the UK from the NHS who'd tested positive to COVID between May 2020 and March 2022 to complete an online cognitive assessment. Of 112,000 who completed the test, 102,000 were included in the study because they were at least 12 weeks post-COVID infection. The cognitive domains assessed by these tests have previously been implicated in post-COVID syndromes. These domains include immediate memory, 2D mental manipulation, spatial working memory, verbal analogical reasoning, word definitions, spatial planning, information sampling, and delayed memory. This study found that people who've recovered from mild COVID lose about 3 IQ points. Those with long COVID lose 6 IQ points, and patients in the ICU because of COVID lose 9 IQ points. Isn't that interesting? Now let's talk about transmission or spread. Here's another myth. COVID is spread via droplets. We heard this ad infinitum at the beginning of the pandemic. In fact, COVID is airborne. How do we know it's airborne? The Lancet published 10 reasons, and here are 6. Number 1, superspreading events have been documented. Number 2, there's higher spread indoors, especially when poorly ventilated compared to outdoors. Number 3, infections have occurred in hospitals despite strict contact and droplet precautions. Number 4, COVID has been identified in air filters and building ducts. Number 5, viable COVID has been detected in the air in lab experiments. And number 6, studies where healthy animals are connected via an air duct to COVID-positive animals results in transmission. I wonder if you can start to think about COVID like cigarette smoke, except it's invisible and odorless. And remember when we thought that aerosol-generating procedures were limited to intubation and extubation and nebulization and using high-flow nasal prong oxygen? Well, that's not what the science says. Anything that moves air through the respiratory tract is an aerosol-generating activity. Breathing, talking, shouting, singing, whistling, coughing, sneezing, playing a wind instrument. If it moves air through the respiratory tract, it also moves aerosols. Going back to the analogy of cigarette smoke, you can detect it visually both near and far from the source. You know that it's densest closest to the source, and it dilutes as it moves away from the source by the square of distance. This is a diagram that shows the continuum between aerosols, which measure less than 100 micrometers, and droplets, which measure more than 100 micrometers. Recall that an average COVID particle is 0.1 micrometers in diameter. Once inhaled, aerosols move with respiration. Larger aerosols get deposited in the upper airway, and smaller aerosols get deposited in the upper and lower airways. Droplets, on the other hand, cannot be inhaled. They're too big and too heavy. They're subject to gravity, and they fall rapidly. This graph shows the time it takes for aerosols of various sizes to fall to the ground from a height of 1.5 meters. For a 100 micrometer aerosol, it takes 5 seconds. For a 5 micrometer aerosol, it takes 33 minutes. For a 1 micrometer aerosol, it takes 12.2 hours. That means that in a poorly ventilated space, COVID can float, linger, and travel for hours. Think of COVID like cigarette smoke, except it's invisible and odorless. The National Health and Medical Research Council commissioned a study in 2020, back when gold standard PCRs were readily available, close contacts were tested, and reporting of positive cases was mandatory. And they found that 30% of COVID transmission came from pre-symptomatic individuals, and 10 to 15% of COVID transmission came from asymptomatic individuals. That has really big implications for infection control. On average, 75% of people are infectious for more than 5 days, 50% of people are infectious for greater than 8 days, and 25% of people are infectious beyond 10 days. Rapid antigen tests, or RATs, tell you when you stop being infectious. They're very good at ruling in COVID because they have high specificity, meaning that a positive RAT means you have a 98% chance of having COVID. Where they don't do so well is when they're negative, because they have a high false negative rate, meaning that if they're negative, you still might have COVID. In Australia, in order for a rapid antigen test to be approved by the TGA and marketed, it has to have a sensitivity of at least 80%. But a study published in the Medical Journal of Australia found that manufacturers' claims of high sensitivity don't always play out in the real world, and sensitivity can be as low as 8%, especially if you don't have symptoms or don't do the test properly. I'd like to pose some rhetorical questions. How can you tell if someone has COVID in the absence of a positive test? Can you see that they have a sore throat? Can you see that they have that feeling that you get behind your nose before the congestion starts? Can you see that they have a headache or a low-grade fever? Conversely, how can you tell if someone doesn't have COVID? How do you know that the person standing beside you in the operating theatres or behind you at the coffee kiosk doesn't have COVID? Is there a way to tell just by observing? Here's an interesting myth that I've been specifically asked to address. Only patients can transmit COVID. In fact, anyone, patients, staff members, anyone can transmit COVID, including those with a false negative RAT, those who are asymptomatic, pre-symptomatic, mildly symptomatic, floridly symptomatic, or post-symptomatic. Anyone can transmit COVID. I want to talk briefly now about hospital-acquired infection because I think it's important to put this in context and to anchor new information to things that we already know. Hospital-acquired infection is obviously a serious problem, and this is Victorian data from the Victorian Healthcare Associated Infection Surveillance Coordinating Centre. They found that in 2022 to 2023, the number of hospital-acquired cases of Staph aureus bacteremia was 550, hospital-acquired MRSA or MRSA was 273, and hospital-acquired Clostridium difficile was 1,600. In comparison, there were nearly 23,000 cases of hospital-acquired COVID in the same period in Victoria, and just over 1,200 who were admitted to the ICU. Now, isn't that interesting? Because think about it. We use contact precautions to protect against MRSA and C. diff, but what precautions do we take to prevent COVID transmission? Especially since we know that it's a much bigger problem, and at least 40% of COVID spread is from people who are asymptomatic. What are we doing to prevent our patients getting COVID in hospital? Now, moving on to ventilation in the operating theatres, I spoke to one of our HVAC engineers and he kindly sent me this table. You can see that in the operating theatres, there's a minimum of 20 air changes per hour. Now, if you can see, the minimum number of outdoor air changes per hour is obscured by this AS 1668.2, which is a hospital standard. So what does this mean? It means that it's not static. We're not getting 20 changes per hour of fresh air. We're getting some fresh and some recirculated. And you can see that in different parts of the hospital, we have different numbers of minimum total air changes per hour. So for example, in endoscopy, we have 6 air changes per hour, with 2 being fresh. So it means that not every part of the hospital is equally ventilated, and not every part of the hospital is equally safe. Some of you saw me walking around with a CO2 monitor, just so I could gauge the adequacy of ventilation in real time in the operating theatres. And for the most part, the CO2 level was below 800 parts per million. But when the room occupancy increased, for example, in a medical emergency call, it would go over 1,000 parts per million. The anaesthetic bay was an interesting place because during sign-in, the occupancy can be up to 9 or 10 people, all facing the patient. So the levels did go up to over 800 and sometimes over 900 parts per million. Endoscopy regularly went over 800 parts per million. The offices in the A tower, over 900 parts per million, especially when there was a meeting in progress. And the worst ventilated place in the hospital that I came across was the pre-admission clinic offices. When those doors are closed, the levels go up to over 1,000 parts per million very, very quickly. Again, just because the ventilation is regulated doesn't mean it's always safe. Let's talk about risk factors for COVID infection. From this diagram, you can see that there's a higher risk of contracting COVID if you spend a long time in a small, crowded indoor space that's not very well ventilated, no HEPA filters, lots of aerosol generation, and no masks. Conversely, there'd be a lower risk of transmission if you spent a short time with no or one other person who was located further away in a well-ventilated space with HEPA filtration, minimal aerosol generation, and everyone wearing N95 masks. So there's a spectrum of risk. I'd like to briefly cover some mitigation strategies. It's a very important topic, but we may need to come back to it in the future. I just want to point out that as per the Swiss cheese model that we're familiar with, all strategies are imperfect on their own. Multiple mitigation strategies are required to improve success. Here's a controversial myth. Hand washing and surface disinfection are reliable ways to reduce the spread of COVID. Now, that would be like saying if a person starts smoking a cigarette in your home, you could wash your hands and disinfect some surfaces, and that would get rid of the smoke. But we know that's not true. Because in fact, COVID is airborne, and airborne mitigation strategies are required. So you'd probably open a window or a door, or even turn on an air purifier. But washing your hands or disinfecting surfaces is not going to help. Remember that COVID is like cigarette smoke, except it's invisible and odorless. Physical distancing really doesn't do much for aerosol transmission. The only thing physical distancing does is it gets you out of the short-range transmission zone. It won't get you out of the long-range transmission zone. In terms of ventilation, this diagram shows that through ventilation is better than unilateral ventilation. For CO2 monitoring, this table shows the percentage of rebreathed air relative to the CO2 in parts per million. CO2 monitors are very handy to have. They're handheld and easily portable, and they can assess the adequacy of ventilation. The risk of aerosol transmission increases with increased CO2. You should always aim for less than 800 parts per million, at which point 1% of the air you're breathing in has been breathed out by someone else. When the CO2 goes up to 10,000 parts per million, 24% of the air you're breathing in has been breathed out by someone else. So the interesting question is, if you wouldn't drink dirty water, why would you breathe dirty air? It's interesting that we've taken clean water for granted for a really long time, but pay very little attention to the cleanliness of the air. Even apart from COVID, High-efficiency particulate air, or HEPA filters, remove multiple different pathogens from the air, from respiratory viruses to mold spores to allergens to smoke, and of course they do remove COVID. During lockdown, we spent years fighting over toilet paper and washing our hands, when really we should have been fighting over air purifiers and cleaning the air inside schools and daycare centres so that children could go back to a safer indoor environment, and cleaning the air inside every public building and our own homes to reduce the pathogen load in the air. So now for a bit more controversy. Masks. They're politicized and stigmatized and personalized, but N95 masks work. And really, they're the only thing that work in the short-range transmission zone. If you look at a surgical mask, it gives you very low COVID protection because it's simply designed to stop liquid splashes. Surgeons wear them when they're peering over a wound to prevent their droplets from landing on or in a body surface or body cavity. They don't create an airtight seal, and air leaks in and out along the path of least resistance between the mask and the face. Whereas an N95 mask filters out more than 95% of small particles, including COVID, and it has an airtight seal with minimal leakage when worn properly. N95 masks consist of multiple layers. They use both mechanical and electrostatic filtration. And most importantly, they provide bi-directional protection. That means that they protect you and also the people around you. And here's the next myth. The myth that surgical masks protect the wearer from COVID is really quite common, when in fact, surgical masks do not protect against airborne pathogens. The Australian Technical Advisory Group on Immunisation are the ones in charge of our vaccination protocols. And from their current guidelines, they've decided that a single vaccine is a primary course. 2 doses are given only if the person is considered high risk. That doesn't make immunological sense. Vaccination is allowed for babies from 6 months of age up to 18-year-olds, but only if they have a medical condition. Annual boosters are allowed for those aged 18 to 64, but we know that vaccination-induced immunity wanes more quickly than that. And 6-monthly boosters are only for those aged over 65 or in the presence of immunocompromise. That leaves a huge proportion of our population unvaccinated or undervaccinated, and it ignores the fact that anyone can get long COVID. I'm showing this slide again because it's important. Surgical masks offer low COVID protection. At best, they can be considered imperfect source control. N95 masks provide high COVID protection due to their multiple layers, mechanical filtration, electrostatic filtration, and airtight seal. Here are tonight's key messages. COVID is a multi-system disease. It can infect every cell that has an ACE2 receptor. Every COVID infection carries a cumulative risk of long COVID. COVID can cause changes in the brain's structure and function. COVID is airborne. Think of it like cigarette smoke, except it's invisible and odorless. Mitigation strategies should be multi-layered to improve success, and they need to be specifically airborne mitigation strategies. N95 masks provide bi-directional protection. They protect the wearer and other people. And remember that surgical masks are imperfect source control at best. Thank you for listening.